Hello, everyone. This is Dr. Vivian Asamoah. If you're watching this, it's probably because you are part of our tribe, the Natural Gut Relief Facebook group, where we've been airing Back to Basics every Thursday for the last 3 years. And our purpose here is to really talk about gut-related issues and natural ways we can heal and relieve gut disease. And we have brought on amazing speakers over the last 3 years, but I'm especially excited to introduce all of you to Dr. Toomer. And some of you may know her, some of you may not, but this is a wonderful opportunity to hear what this expert has to say and ask some questions later on. So I would like her to do the introductions, but let me just say what I know about her. She's a very special person. She is a physician. She practices what she preaches. She really, really walks her talk. And she has founded the Total Weight Care Institute. Founder and CEO, leads this, not only leads and helps patients, but also leads and helps physicians through her multiple courses. I'll let her dive a little bit deeper into this, but guys, this is a treat. So hold on. We can ask questions later, but I'm going to give the floor to Dr. Toomer. Big welcome. Lovely to have you on today. Dr. Toomer, tell us a little bit about you.
Thank you. Well, now I got to live up to that. Okay, let's see.
You will.
Okay. Well, I am Dr. Toomer, and I am a family medicine and community health physician by training, University of Florida, wonderful place. That also, when you said, natural gut health, I was trained actually in a very holistic, friendly program. We had a masseuse, we had an acupuncturist, we had an herbalist,
Wow.
we had our PharmD who taught us was also an herbalist. And so
Wow.
we had a really wonderful holistic approach to medicine. And I had learned the biopsychosocial approach to medicine in medical school. And so I just kind of took that, and I created my program around that approach, mainly because my program was created because I really created it to save my own life.
Mm.
Um, I, after med school and residency, my stress-related weight gain had gotten to the point where when it met my genetics, I was an insulin-dependent diabetic, 100 pounds overweight. A month after my daughter was born, I went into congestive heart failure, and
Mm.
nobody would touch me when I asked for help. And so my husband, who's also a physician, and I created my own program to help me lose weight, which eventually led to a 100-pound weight loss
Wow.
and surviving my my heart condition, which I had a 1% chance of living a year, maybe five. I'm sorry, 50% chance of living one
Mhm.
year, maybe five. I was put on a heart transplant list, so I knew I needed to do something. And so what I use now for my program to help my patients maximize their health and wellness through weight care, and also I teach physicians compassionate and comprehensive weight care for their patients as well, so that nobody gets shamed and turned away the way I was. And that's essentially what drives me.
Fantastic. Really, really fantastic story. It's something that made basically you were in a sort of ultimatum situation, right? You had to really make a decision to change things. And this is definitely, I can say, for a lot of patients in that situation, they have to decide it's either do or die at this
Yeah,
point. And what am I going to do? So you're in dire straits, right?
exactly.
And it took you getting there, even as a physician,
Hmm.
to realize that, hey, I got to live for my family. I got to live for me. I want to live this life. I want to be a part of it. I think with the obesity problem we have in the United States, a small percentage of patients may be in this do or die situation.
Hmm.
Most of them don't see it imminently. Like they just, I'm a
There,
little overweight, I maybe a little high blood pressure, I got diabetes, I can take medication, but they're not in that situation, which may be why it's so hard to see change, for them to actually adopt the behavioral changes quickly.
Mhm. Well, this is the thing. And really what we're talking about is having too much fat in the body, whether large or small, or old or young. It's all
Mhm.
about having too much fat and what fat does in the body to inflammation, to our cancer risk rates, um, our arthritis risk rates, all the other, as you see, I'm sure in your practice, it just complicates everything. It complicates treatment. It complicates the psychosocial part of it. People have been so dismissed and shamed that it's hard to get through to some people. They're very
Mhm.
resistant to with physicians. But one of the things that I say, um, obesity specifically is a metabolic chronic disorder.
Mhm.
With any other disorder, we treat when it's severe.
Mhm.
And then we start talking about lifestyle changes, and we start talking about what we can do to then try to either reduce the amount of medicine needed or just kind of help somebody along so that their disease state doesn't cause them problems. Obesity really is the only time we start talking about lifestyle first.
Mhm.
And so, and part of that is because through medicine, we learn in an apprentice system. So everyone's biases and prejudices are passed on from one generation of doctors to the next. And unfortunately, our attitudes about being overweight and being obese are one of those prejudices that get passed along.
Absolutely. That is so true, 100%. So I noticed that your practice is called Total Weight Care
Hmm.
Institute. And so
Yes.
there must be, there's probably a deliberate and very intentional decision as to why. Tell us
Hmm.
a little bit more.
Because it's about um, getting people healthy, but based on their weight care. So often that weight is really fat. So I actually have people who are not overweight who I help. And mainly because they're on the verge of diabetes, they have a family history of early heart disease, and they want to get healthy. And often what brings them through the door is the change of their weight.
Mm.
And so that's why I say weight care, because honestly, for most of us who um, are walking around, not physicians, even as physicians,
Hmm.
weight is a symptom of something else. And
Absolutely.
that's and it's what we notice first, either it going up or coming down. And it's any change we just don't like. And so I say weight care because I know that by taking weight, I can find the cause of that weight change, and it's something else, and I can take care of it. It's really healthcare using weight as the draw, as the thing that pulls people in.
I think that's such a profound statement. And if everyone in the audience can really hear that today, I think it goes a long way in terms of prevention of disease, right? Weight is a symptom of something else going wrong. Weight is the end result we see, it's the first thing we perceive. But what's going on silently in your body, the changes that are happening in terms of insulin resistance and metabolic syndrome, we don't notice until the pounds start packing, right?
Yes.
And so
Hmm.
this is really, really important. I'd love for the audience to really get this profound statement there. I went ahead, Dr. Toomer, and just curated a couple of questions that my patients have asked me in clinic. And I'm
Okay.
not a weight expert, but I do see a population of patients with fatty liver disease. And
Hmm.
that really, I think, translates into what you're saying, that, some of them are skinny.
Yep.
Some of them are just average weight. You wouldn't tell them to lose weight, but we're just kind of waiting for things to happen. Of course, their fat distribution and fat mass is totally different. And
Yes.
that's what we need to address. That's what's causing
Mm.
the inflammation in the liver and the high liver enzymes. But some of the questions that come at me are very, I would say they come from all sources, right? A lot of them
Mhm.
from social media feeds. So this is a
Yes.
wonderful opportunity for us to get an expert in weight care, really dispel some of the myths, tell us what's true, what's not true, what we should be paying attention to. So,
Hmm.
a common question is, hey, doc, what
Hmm.
diet should I be on?
Yes.
Should I do carnivore? Should I do vegan? I'm doing intermittent fasting. I'm doing both. I'm doing cabbage. And I'm like, whoa. And they're like, well, I saw this guy on TikTok and he
Hmm.
said this and he said that. So the landscape is flooded. And
Yes.
what do you typically tell your patients when they ask you this question? What should their next step be as they're trying to
Okay.
make
What
changes?
I say, there is no diet to diet. Essentially, what we should do is eat intuitively,
Mm-hmm.
eat based on what we enjoy, what we like to eat, what because I feel that food is a self-care mechanism, and not a self-soothing mechanism necessarily, but a self-care mechanism. And the way we do that is by eating the foods we want and then kind of offsetting what we want. If it's something that can cause us a problem, we offset it either by reducing the amount so it doesn't cause us an issue, or changing the way it's been prepared so it doesn't cause an issue, or adding other healthier options or other healthier components so that we can get away with that little cheat, so to speak. Um, and so that's how I tell people to eat. One of the things that I also let people know is empower them in making those choices, because a lot of times our food choices, many times our food choices are biopsychosocial. It's our biology driving the cravings, which is basically our glucose dysregulation acting on our brain, making us wanting to eat certain things.
Mm-hmm.
Or and that dysregulation could be caused by stress, which is why we stress eat. Um, and then, or it's something we learned to soothe ourselves with food because of psychological issues,
Mm-hmm.
or our body changes what it does with food based on our psychological makeup,
Mm-hmm.
or we learn certain behaviors from our families.
Mm-hmm.
And so it's important to address all of those things when looking at your food. And so just thinking, why am I actually eating? Just ask the question, why? Am I eating it because I like to? Am I eating it because I need to?
Mm-hmm.
If you're eating it because you need to, go right ahead and just eat it. If you're eating it because you like to, look at it and decide, is this something that's going to make whatever is going on in my body worse? If
Mm-hmm.
it is there some way I can change this so it doesn't do as much damage?
Mm-hmm.
And then ask yourself, why do I not care if I eat this thing knowing it's going to cause me a problem?
Mm-hmm.
It circles back to the psychological.
Mm-hmm.
Something I think that we overlook quite a bit is the how much depression and anxiety plays into our food choices,
Mm-hmm.
and how much it plays into us not caring about our food choices. And so sometimes when we say, how should I eat? You should eat in a way that makes you healthy. You should eat in a way that makes you feel good. You should eat in a way that doesn't damage any part of your body.
Mm-hmm.
And if you can't do that, find out why. It's not willpower. It's not discipline. There is an underlying psychosocial reason for it. And you need to do that. And one of the things I did for myself is I treated my depression.
Mm-hmm.
I
Mm-hmm.
was so unmotivated to even looking at my babies, knowing that if I didn't do what I needed to do, I could die and leave them without a
Mm-hmm.
mother. I
Mm-hmm.
still had a hard time, and I couldn't figure out why. And it was postpartum depression, cardiac depression,
Mm-hmm.
chronic, mild chronic depression, and then treating that depression. So even
Mm-hmm.
now, I always screen for depression, anxiety, ADHD, because those all affect how people behave with food, around food, and what food does once it's been eaten. And so to answer a long answer to your question, how should people eat? Eat the way you want to, but in a way that doesn't harm you, doesn't do more harm than good.
So I think that really does sum it up. And when we talk about food,
Hmm.
nutrition, and the psychosocial aspect related to it, I really feel that sometimes that's in the middle or the end of the conversation, but
Hmm.
that's where it should really start. I think
Exactly.
that's where we should really start. So in your practice,
Hmm.
generally, how do you bring up this conversation with patients, and how is it often perceived? Do you bring it up right away in the first couple of visits? Does it depend on the patient? How do you go about it, especially when it comes to talking about even how you use food? Is it soothing for you, or is this truly an addiction that you crave for? Tell us
Hmm.
a bit more about how you work and how you navigate things.
So first, what I do is I look for the cause of weight gain. I always look for the cause. Rarely is it food related. It's definitely, if it is food related, it's not food volume related. I can tell you, as someone who is 100 pounds heavier, I eat far more now than I did when I was 100 pounds heavier.
Absolutely.
It's what your body does with that food. And so I look for whatever the metabolic cause is and why the body acts the way it does towards food and why certain choices are made, because it is this vicious cycle of choosing things like carbs when carbohydrates cause issues, and then it just starts this vicious cycle. So I do that first. I don't even have the first conversation is never about food other than
Mm-hmm.
what you like to eat. What's your favorite carb? And so I'll tell people, it's like, well, I like to eat such and such. Okay, well, if you like to eat this, this is how you add protein so that that carbohydrate doesn't cause you as much of a problem.
Mm-hmm.
So generally so what I do is I only focus on what people should be eating, not what they can't eat.
Mm-hmm.
It's so much easier to look at something and say, I can eat that, I can eat that, I can pick things I can eat rather than
Mm-hmm.
I can't touch that.
Right.
No, it just creates a stress reaction around food that defeats the whole purpose of enjoying food.
Mm-hmm.
So I always talk about how to maximize protein, and that's usually the conversation. And of course, when talking about maximizing protein, you have to talk about the biology of is your kidney function fine? Is your liver function fine?
Mm-hmm.
Is, do you have, the types of protein that you eat, is it going to change your cholesterol levels? And so there's
Mm-hmm.
all these things you've got to play in, but mostly the conversation is simply like, what makes you happy?
Mm-hmm.
And let's figure out how we can keep you happy while also getting you the health that you want and need.
Absolutely. Absolutely. Okay, that makes a lot of sense. So you often do a questionnaire to screen for depression, anxiety, and whatnot, right? And if you identify, of course, positive measures that suggest this person has some underlying depression or anxiety, what's your next step?
Well, as a family physician and as someone who is very well trained in psychology and the use of medications for in the psychosocial realm, if it's within my wheelhouse, I'll treat it. And
Okay.
at the very least, I'll suggest a treatment for them if some people come to me just for advice and
Hmm.
counseling. And so I'll just give them suggestions to take back to their own primary care doctor.
Okay.
Or I'll suggest if it's something more severe, I'll say that you really need a counselor, and I have a list of resources for counseling.
Okay.
The other thing that I also do, depending on what I find, I also do what's called an ACEs screen, which
Hmm.
basically looks for childhood trauma.
Hmm.
I have never, ever, ever met anyone who was morbidly obese who didn't have some childhood trauma connected to it in some way.
Absolutely. Yeah.
And so now that type of counseling is outside of my
Mhm.
wheelhouse, and I always refer.
You refer.
Usually it's a combination of I might take care of the medical part, medication, refer for the counseling, and it really just depends from person to person.
Hmm.
Um,
Hmm.
what I find and what I feel that they need and how comfortable I think they are going to be following up and following through on the plan.
And that's really important in terms of determining success, right? It's really important that not only they working on the foods and identifying nutrient rich foods that work for their body, but they
Mhm,
also have to focus on the underlying potentially root cause of the
mhm,
behaviors and the decisions that they're
mhm,
making. In your experience as an experienced weight care expert,
mhm.
how often are patients receptive to getting coaching, getting therapy, being started on a medication to be able to see success with their weight care journey? What
Most
percentage would you?
always.
Okay.
And mainly that boils down to me, not them. I have to be able to explain things in a way that help my patients understand why I am making this choice or why we're discussing the choice.
Mm-hmm.
And I give them a couple of options, give them outcomes with each of those options, and then let them choose which they're most comfortable with. Usually what happens, they'll choose one. If it's not the best choice, they'll go with it for a little while, and it's like, okay, I think it's time we go up or check one of the other things you talked about. And I'm fine. I'm very patient. I don't do anything on my own timeline, on my own timetable, because that's a quick way of losing someone to follow up, and then I do more harm than good. And so I'm very, very patient and very, very, I'm a partner in their
Mm-hmm.
process. I am not the driver of it
Mm-hmm.
at all. And so usually what I do, and I find that when you do things in small increments, one step at a time, you hit the big, something my father actually told me once when I was in medical school. He said he went to his doctor, and his doctor said, okay, let's think about what's going to most likely kill you in the next 5 years, and let's start there.
Mm-hmm.
My father was like, oh, okay.
Uh-oh.
He was like, oh, whatever you tell me, I'm going to do it.
Uh-huh.
It was okay. And once we get through those, we'll do the next 10 years, and then the next 15, then the next 20.
Wow.
My father lived to 90. He was the only
Wow.
male in his family to live past 60 in 5
Wow.
generations.
Right. So,
And so go ahead.
so
Sorry.
that personalization of care,
Absolutely.
the patients to walk through, collaborate, partner with your patient,
Yes.
and which is often, as physicians, we kind of want to lead. Hey, this is the next step. This is what you got to do.
Well, you
and
have
I
to do
think,
what I say,
well, you have
even
to
though
do
it's
what
not
I
as I do, because
But
we know many of us are
as I
not the
say,
healthiest out
no,
there.
we're not. We're not. So that is really interesting. We're going really deep, guys, but I think these are very important conversations for us to have and hear, so you understand what the journey of weight care really is all about. And we're going to talk about instant gratification options that are available now. But let's also, I just wanted to go back to something you said. You said, I always try and find the cause. I always try and look at the biology. So what, when someone comes and says, I'm eating the right foods, and of course you realize that, hey, okay, or they're like, I don't eat a lot and I'm still gaining weight. And what I hear about from you is, well, what are they eating? And how is their body metabolizing this, right? And is it the right foods for them? So that's one. And some people are like, well, I'm exercising 3-4 days, whatever, 5 days a week. And, I feel like my stress is controlled. If you concur, with that person and you feel like check, they're true. They're doing everything right. What else do you look for, Dr. Catherine Toomer? What else are you digging for in terms of biology?
Well, in terms of biology, I'm looking for any metabolic issue going on.
Okay.
And look for also any psychological reason that might be changing their biology going on.
Okay.
But part of that is also finding out what their expectations are and are they realistic. Some people come to me because they say, yes, I'm gaining weight and I don't like it. Well, if you're gaining weight coming from a low BMI, maybe it's your body saying, you really could be a whole lot healthier if you gain 20 pounds. So someone walking in saying, I really want you to help me lose weight. I know I'm not really overweight, but I don't like the fact that I'm gaining. If it's a woman who's not perimenopausal, who has no biological issue underlying and was eating fine and exercising, I'm like, it's probably muscle. That's a good thing. You're gaining 20 pounds of muscle. And I do nothing other than reassure them and then say, if you want to keep coming back and having these conversations so I can keep reminding you that you're actually doing a good thing for your body, then we can do that. And so not everything is a pathology. And not all weight changes are pathologic. And so it's my job to look to make sure there isn't any pathology going on. And if there isn't, then sometimes that pathology is actually psychological, not even physical.
I see. Got it.
And so when it's about gratification and it's about instant gratification, there's nothing wrong with that. We all do things that make us feel happy right at that moment. The key is moderation. And why? Again, are you doing it to harm yourself? Are you doing it to appease somebody else? Are you doing it because, you're like, listen, I had a bad day and I don't have very many bad days, but today I did, and I'm having a cookie and,
so be it. Yeah.
And I'm like, have your cookie because, just make sure you have one or two and don't, or, instead of using milk, use a vanilla protein shake as your milk, and it offsets the sugar. And so it really, the main thing I do a lot of is just appeasing guilt also, because a lot of what's happened to many of us who are overweight is that we've internalized the shame and the judgment of being overweight that has been imposed on us from other people. And so we can be harsher on ourselves than anyone else, but because we were told that there is always something wrong, and sometimes there just isn't.
Can you say that one more time?
We're always told that there's always that we're told that there's something wrong, and
And
sometimes
sometimes there just isn't.
there
It's
just isn't
true. There
anything wrong.
just isn't anything wrong. Yeah.
We've just been convinced that what some state we're in is wrong, and
Yeah.
so we feel like we have to do something about it, and sometimes we just simply don't have to.
That is so true.
Other than love ourselves, change our
Yeah.
attitude about ourselves rather than about our process or where we are.
Yeah. And I think it starts there. I think it
Mhm.
starts there. Yeah. It starts there.
Yeah.
Okay. So let's jump into, I wanted to go back a little bit into biology a little bit.
Mhm.
Are there certain tests that some patients that you do routinely on patients just to kind of
Mhm.
assess, as you mentioned, in
Yes.
metabolic syndrome? Yeah. So what
Mhm.
types of tests do you do?
So what I do is first I always check thyroid, a thyroid panel, not just a TSH. We've been fooled a lot into thinking that our thyroid's fine because we have a normal TSH. When in fact, if you do a full panel, often what I look for is to see if the TSH and the stimulating hormone and the final hormone are on the same level. Because often what will happen, we'll say normal, the TSH will be normal high, and the thyroid hormone will be normal low. Our body doesn't read textbooks. Our body feels that is hypothyroidism and acts
Mhm.
like it's got hypothyroidism. And so I do the whole panel to look. The other thing that I do is a glucose tolerance test, but a non-fasting glucose tolerance test, mainly because most of us, when we eat a piece of cake, it's after we've had a meal. So we
Mhm.
want to know what our body does with sugar after we've already eaten. And
Mm.
so what I do is I have people either get an actual glucose tolerance test, and then I check an insulin level, not during fasting or not at the beginning, but after they've been challenged by glucose, because insulin resistance is a meal related disorder.
Disorder. Yeah.
And
Process.
so
Yeah.
I always want to see I always want to see what a person's body does under normal situations, not a
Mm.
manufactured fasting situation, which most of us don't function like that.
Now, is it helpful to look at both? Because I do look at fasting and I do look at postprandial glucose as well. Is it
Hmm.
helpful to look at both fasting insulin and um, postprandial insulin as well, or you don't see the benefit? Because sometimes I can tell with a fasting insulin is elevated that,
Well, you
yeah, there's,
can, but my
right?
thing is if I do the non-fasting and it's abnormal, it tells me everything whether it's fasting or non-fasting. It's
Okay.
like it depends. It depends on insurance. It depends on whether it's going to get covered. It depends on the person's patience, whether they're going to actually sit there long enough for me to get it done. So
Mm-hmm.
sometimes what I'll do, if I know somebody's not going to sit there for an hour or 2 hours to get their different,
Testing.
I tell them drink glucose before you go get this. Schedule
Got
your test, go drink glucose right before your test, and I
There
just
you go.
order it right at the beginning.
Okay.
And
Okay.
because it really just depends on the person. One of the things that I pride myself in, and actually was actually kind of drummed into me, is don't just focus on the science of medicine, also focus on the art of medicine. And
Mm-hmm.
so that's one of those things where you just like, what really works best
Mm-hmm. Mm-hmm.
for my patients, what really
Mm-hmm.
works best for this person. I'm
Mm-hmm.
not going to do something cookie cutter just because somebody told me to do it that way. And so, so everyone's different. There's some of those patients you're like, you know what? I need to do some fasting labs on you just to prove to you
That, yes,
that
yes.
your normal labs didn't mean anything.
Right,
So that
right,
when I
right,
do
right.
it the way I do it and you see how different they are,
You
it
see.
proves to you that all those fasting labs that you've had for years
Mm-hmm.
didn't mean anything, and stop looking at me like I have two heads because I'm telling you that you have metabolic issues. You know?
I like that. So thyroid, insulin,
Mhm.
postprandial glucose, anything else?
Um, that's it.
Any
I think,
differences between men and women? Is there anything you do differently or pretty much the same
now I
major
will check
metabolic?
testosterone in men,
Okay.
mainly because um, their levels matter. Testosterone levels will determine how well we can actually adjust their metabolism using muscle. If
Mm-hmm.
men's testosterone's too low, and I'm telling them build muscle, and their testosterone they don't have the testosterone to supply that muscle or to make
Mm-hmm.
that muscle, then
Yes.
what I'll do is I test it. The other thing that I do is check their cholesterol.
Mm-hmm.
Often what we'll
Mm-hmm.
do is we'll give men cholesterol medication. We drop their cholesterol so low, their body can't make the testosterone that it needs
Mm-hmm.
because testosterone is a cholesterol
It's a
related
cholesterol
uh,
form, yeah, fat.
hormone. And
Mm-hmm.
so we forget and give people, yeah, we get their cholesterol levels down, but now they can't make testosterone, so it's causing other problems. The other thing that I also look for, you see a lot of diabetics on metformin. Metformin also drops testosterone.
Mm-hmm.
And
Mm-hmm.
so we use that to the advantage of women who have
Mm-hmm.
polycystic ovary syndrome to drop their androgen levels or their testosterone, but it also harms men. And so they might be diabetic, but we're also they're diabetic. They already have issues with lipids because of their fat
Mm-hmm.
profile. And then
Mm-hmm.
we're dropping their testosterone in the process. And so one of the things that the new medications, the GLP-1s have done that have been
Mm-hmm.
such a lifesaver for
Mm-hmm.
diabetics for the last 20 years is that it's been able for us to not depend on metformin to get diabetics under control.
Right, right. This testosterone and metformin relationship is something I need to pay more attention to, because I'm glad you bring it up. With all my fatty liver patients, especially my men, I'm not checking testosterone, which I really feel I should do, because some of them I'm putting on metformin. So I really have to look at that. So thank you for that. Thank you. But you brought up those three important letters, the GLPs. The
Mm-hmm.
GLP-1s. And I just wanted to hear from you. I do prescribe it in my patients, but
Mm-hmm.
I think us as physicians and practitioners, and also to be able to share this with the community at large, is what I would love to hear from you is, who would you not prescribe a GLP-1 to? Not just for the thyroid issues and the whatnot, but truly just from your experience, your expertise, and having used it for a number of years, who would you not recommend it to or prescribe it to?
Well, there's no blanket. It really is very individual. Some of it is just my gut, like someone who tells me one thing, like I'm listening for potential eating disorders,
Okay.
and so I may not, or I may say yes, I'll give you a low dose. I'm going to keep you on that low dose for a while until we go to the next and see how you behave around the medication.
Mm-hmm.
Sometimes it's not what the medication actually does, it's the psychological impact of taking that medication that can be an issue. And
Mm-hmm.
so I watch. And so it really just depends. And I know, we hate this, or just depends, but it really just depends. There is no one person. The only time I would not absolutely give anyone a GLP-1 is if they are not overweight, have no secondary diagnoses that make it appropriate, who are simply their reason for wanting to take the medication or wanting the medication is not even remotely related to health.
Mm.
Now, those people, I'm like, I'm sorry, I'm sorry I hurt your feelings, but I'm not prescribing it for you. And I'm sure there are people out there who might, because
Mm-hmm.
they'll pay them and they'll do it. But just recognize that you're running there's a risk involved. So I always make sure those people know what those risks are. But most people who come in, even if it's just for peace of mind, even if it's just for self-love, there's always something I can do, even if it's to redirect them away from the medicine.
Mm-hmm. I like that. That's true. That's important,
So
right?
it just
Yeah.
depends.
Yes.
But
Yes.
with so much out there, it's really, really become hard because, like, again, it's feeding in the frenzy. Is part of the frenzy is that self-hatred, that self-incrimination that we've been taught.
Mm-hmm.
And we've also been taught that thinness has currency. There
Yeah.
is thin privilege in the United States. And
Yes.
so we're telling people, don't want this medicine that we know is going to help you psychosocially.
Mm-hmm.
Even if you
Mm-hmm.
don't need it biologically, it's still
Mm-hmm.
going to help you psychosocially, but don't want it. Don't use it.
Are we
And
are we really telling people that? Because I'm not telling people that not
no,
to
no,
use
no.
it.
I'm saying is there are people out there. You're taking it from diabetics. That's what I hear a lot. You're using these
Oh, in
medications. You're
that
taking it away
sense.
from
Yeah.
diabetics, or they say, I bet she used that medication like it's an accusation.
Oh, I get you. Absolutely.
And I'm like,
Absolutely.
yeah,
Yeah.
he probably did.
Yeah.
Good. Because, and like I tell people, if you take Tylenol and you don't have a headache, it doesn't do anything.
Right.
The
Right.
same
Right.
thing with GLP-1s. You take a GLP-1 and you lose weight, then there's something going on that
Right.
is changing. Because
100%.
the gut motility issues that slow down gut motility that cause you to get full faster or increase your satiety is, one, temporary, and two, is very minimal. There are other medications that are better appetite suppressants than a GLP-1 if it's mechanical. Now, if
Mhm.
it's central, then that means there's a metabolic issue, because the only way it works in your brain is if your brain is misusing glucose already.
Okay.
So,
Okay. So that makes a lot of sense. So you do use it, you do prescribe it for the right patient,
mhm,
and generally you think that if there's a health impact, not
mhm,
just diabetes, but whatever health impact, then
mhm,
it definitely is beneficial.
mhm.
It's
And one
definitely
of the
something
things I
to
think we're
promote.
going to start seeing is it's used in a lot of different ways. It's being studied for Alzheimer's. It's being, I mean, for dementia.
Mm-hmm.
We already know it affects addiction.
Mm-hmm. Mm-hmm.
Many people have stopped drinking, stopped using drugs, have have their panic attacks have stopped.
Mm-hmm.
So that's not addiction, obviously, but like a lot of mental illness things have,
Mm-hmm.
because our brain only uses glucose and ketone
Mm-hmm. Mm-hmm.
function. So when
Mm-hmm.
we start controlling, helping it use its glucose better,
Mm-hmm.
all brain functions. The other I think we're going to start seeing is going to be standard of care is using low dose GLP-1s in women who are perimenopausal.
Mm-hmm. Absolutely, to help bridge that gap in terms of the hormone change.
Yep.
Well, with the GLP ones, I think it's making a huge impact on the gut microbiome,
Yes.
and not only from a glucose standpoint, but even how we're making our neurotransmitters, right?
Mhm.
How we're breaking down and absorbing our foods,
Yes.
how we're breaking down and making our nutrients that are necessary for the body, and all of this impacts even just
Yes.
beyond the brain, but everywhere else. Yeah.
Mhm.
I feel like we could talk forever, Dr. Toomer. I'm learning so much and I love hearing your perspective on this. But
Yeah.
I don't want to take up too much of your
Oh,
time.
fine. I'm good.
I have one question for
Mhm.
you. And I'm really speaking from my patient's perspective, from the
Okay.
people in my tribe's perspective, right? If you are looking for trying to lose weight and looking for a weight loss or weight care
Mhm.
center of
Mhm.
excellence,
Mhm.
what are some things as a patient? What would you recommend that they look out for? What are some key points or
Mhm.
key deliverables,
Mhm.
that they offer, and what would you shy away from? Like if you saw they were doing this, hey, maybe that's not the center for me. Just give us some practical advice when we're doing our research, so we're not influenced by social media and all that
Mhm.
blah blah.
Unfortunately, because weight loss is a multi-billion-dollar industry, more often than not, weight care excellence is an oxymoron.
I know.
And so, what people need to look for, and this is what I tell people, if you go to someone, they tell you something wrong, and that same person sells you the fix, run. Even if it's a physician,
Mm-hmm.
walk away, because they have a financial stake in telling you that you have something wrong with you.
Mm-hmm.
If you can get whatever medication through an FDA approved pharmaceutical company, and you go to someone and they don't even try to get you that medication that is branded, that is FDA approved, walk away.
Mm.
Other options should only be as a last resort. And when I talk about only options, I mean compounded medications, and compounded medications even then should be from an FDA monitored facility.
Facility, pharmaceutical compounding
Yes, and
facility.
you can look those up. There are a
Yeah.
list of them, and you can
Yeah.
look them up. You can
Yeah.
Google them. And so you can ask, where is this? What's the source of this medication?
Mm-hmm.
The other is ignore social media. And if anything, let me put it this way. If ever you are required to do something that is outside of the already well-established FDA guidelines for a medication, walk away.
Mm.
If the doses don't match, and this is what I tell people, I don't care what medication you're on, you should know the names and you should know the dose. If
Mm-hmm.
you cannot tell your dose in milligrams, then you're probably taking something. If someone says, I'm taking it in units and it's not insulin,
Mm.
question it.
Right.
So it's just really, let your sense of self-preservation override your desire to lose weight.
Mm. And look at the long term consequence or the long-term benefit, just kind of what is this going to look like down the road?
Well, the
Because
problem is that we've already told people their benefit is that they're going to look a certain way. Their benefit is that they're going to have this currency that society has told them is more important than anything else.
even health. Yes.
Exactly.
Yes.
And
Yes.
so, it's not, GLP-1s aren't the first time that people have abused a medication to try and get thin.
Mm-hmm.
Or
Mm-hmm.
abused anything to try and get there. Starvation and all sorts of things, even though they're temporary. The only difference is GLP-1s now are more of a permanent fix because they're safe long term.
Mm-hmm. Mm-hmm.
And so, so it's really hard. It's not even so much the medication. We have to change the culture around the whole process.
I was that, and I think it has to start very early. It has to start very, very early. And I just want to highlight, just what you mentioned about shame. We are currently looking for a new pediatrician for our daughter who is just 10. But ever since the age of 7, every time we go for a visit, she says, Hannah, you're chubby and you need to, we're going to have you exercising more. And, what are you eating? What are you eating?
So that's a conversation you have with the parents anyway, because no 7-year-old is making their own food, grocery shop.
Exactly.
And that's a conversation with the parents. And the thing is, if it's happening in a 7-year-old, you still need to find out why.
But the thing is, she's not even overweight.
Well, that's what I'm saying. So there could be an underlying
issue,
metabolic reason.
And we have to look at the metrics that she's using to also determine that she's, overweight. She's very healthy. She's in the swim team. She does all these things.
Exactly.
And so it's like after 1 or 2 visits, every time after that visit, we have to pull our daughter aside, have a whole conversation with her about what she understood, what was said, and try and redirect the whole conversation. And I'm like, she's only 7.
Exactly.
And her weight is perfectly fine. And so I was like, well, we got to find the right type of provider for us.
Exactly.
But
that's something I have to say. And I'm just going to give a little example. And I know that we're running long. My mother is, and I'll just give this as an example. One of the reasons I got to 100 pounds overweight, more than 100 pounds overweight, I stopped weighing myself at a certain point, was because I never cared. I never judged myself based on my body size. One, I happened to marry a man who also didn't care. So he never really said, you think you should lose a little weight? Never heard that, ever. And so I just kept getting, and so it wasn't until I got ill that I was like, wait a minute, well, how did this happen? And I realized, well, because you're unhealthy, because obviously something is going on. So I started thinking about why that was the case. And I realized it's because my mother always celebrated how she looked. I never once heard my mother say she needed to diet. I never once heard my mother criticize any part of her body. If anything, she used to just be like, I'm cute.
He just embraced it. This is who I am.
My father would make little comments and make just to embarrass us. And we're like, but I remember being 7 years old and looking at my mother and watching her put on a bra. She's a woman who had 8 children. And her bending over to put on her brassiere and looking at her thinking, wow, she's got stretch marks and she has rolls and I can't wait until I'm a woman and look just like her. And that's why, and that's exactly what happened. So as I was growing, getting bigger, I kept thinking, I'm a woman. But of course it got maladapted and I ended up being ill. However, but it made me realize that it was that messaging that made me feel good about who I was, no matter where I was. And so I made sure my daughters never heard me say, I can't eat that. I'm on a diet.
I'm on a diet. Yeah.
Or I can, and that's really what, it's so easy to pass that message on to our children. They should hear us talk about getting strong. Now, my children love going to the gym because they hear me talk about, I need to get into the gym because I'm starting to feel a little weak.
Yeah, I need to get stronger.
Strength.
Right.
But it wasn't until later that I really made that very intentional. And that's for fathers too, not just mothers.
No, it's true. And I wish that the with your situation, the impact from your mom was profound. I mean, it really lasted. But what happens at home, unfortunately, is not what stays within that child's mind, right? It's what they also hear at school, what they see on TV. And now in the era of social media, they are just constantly exposed to this, right? And so they're getting this thrown at them from all sides, even if it's not the same narrative at home. So I really agree with you that the conversation is a socio-cultural conversation. Like there has to be a complete mindset change about weight and weight care and how we view health and weight. I think that's so important.
Yes. I don't know if you can hear me or not,
I can
but
hear you, but you're frozen like this. And
yeah,
I'm like, what's going on?
well, as long as you can still hear me, that's good. But yeah, somehow we're actually having some storming in the area. Whenever that happens,
Oh,
sometimes the Wi-Fi gets a little wonky.
okay.
So
Okay. Well, this has been an amazing conversation, very profound. I have learned a lot. Thank you for sharing a little bit about your journey and your work with the Total Weight Care Institute. It sounds phenomenal. Where can the audience find you? Because you are virtual and global. Dr. Toomer, you are big. So where can they find you?
where they can find me, the best place to find me is on my website, drtoomer.com. And that's drtoomer.com. And there you can send a message. I have people monitoring it all the time, and we'll get back to you as quickly as possible.
That's fantastic. Thank you so much for being with us today. We will post all your links in the show notes afterwards and post it in the comments section as well, so everyone can learn more about you, learn more about what you're doing, and connect if need be. I think if you are on a serious weight care journey and need help, Dr. Toomer has the experience. I think she's the right person to go to. Definitely highly recommend, and know a lot of colleagues who've worked with you and had some amazing results.
Well, thank
Amazing
you.
results. Yeah, so I'm really
Thank you.
excited. So, you guys, everyone, thank you so much for being with us on another session of Back to Basics. My name is Dr. Vivian Asamoah. We had the pleasure of talking to Dr. Catherine Toomer from Total Weight Care Institute. My practice is the Houston Gastro Institute, based right here in West Houston, Texas. Our practice is different because we blend the best of both worlds. I'm certified in gastroenterology and also certified in everything that's integrative, functional, holistic medicine to really be able to deliver optimal gut care to all our patients, especially patients with chronic gut issues who have not found resolution with conventional medicine. So if you need any additional information or you know someone who may need our help, please message us at contact at Dr. Asamoah, Asamoah, ASAMOAH.com. Until we meet again at another session of Back to Basics live every Thursday. Thank you for joining us.
Good night.